Okay, so let's talk about the different types of synovial joints. Remember, synovial joints are the major joints of the body. When we think about joints, things like your elbow, your wrist, your shoulder, your hip, your knee. Okay, we're thinking of synovial joints. Synovial joints have that property of being able to move very freely, some more than others. Okay, and we categorize them into these 6 categories, kind of based on their kind of structural makeup and what type of motion that they permit. Now, what you guys can see there are 2 names for each of these. The one that's bolded that you're filling in the answers to is the one I want you to know for the exam. Okay, so you don't need to worry about what's in parentheses, just what is bolded. Okay, we'll start at the top, what we call planar or gliding. Now, if you just want to call them plane, that's what they're actually listed at down here. Planar, plane, same thing. Okay, also go by gliding, not that you need to know that, but the surface or articulating bones are flat or slightly curved. Okay, and they permit back and forth and side to side movements, which will be described as biaxial. Bi, hopefully you guys all know by now, it's a prefix that means 2. Okay, if you think about the 3-dimensional world, there's 3 axes, like front to back, side to side, and up and down. Okay, planar gliding joints can perform 2 of those. Okay, examples of those include intercarpal and intertarsal joints. Thinking back to last week, we learned that intercarpal joints, that's not your wrist, that's within the wrist. So like when the scaphoid and the lunate, which are right next to each other, they slip and slide over one another. As you move your big wrist joint, your true wrist joint, okay, the bones in there are kind of slipping and sliding. That's why we call them gliding joints, because they perform that gliding motion we talked about the other day. Same thing for intertarsal joints within the ankle, between the different tarsal bones. Okay, sternoclavicular and acromioclavicular, we talked about those in our last lecture. Remember, the sternoclavicular is the connection between the sternum and the clavicle, and then the AC acromioclavicular is between the acromion of the scapula and the clavicle. Okay. Hinge also goes by Ginglimus joints, are where you have the convex surface of one bone fitting into the concave surface of another, which produces an opening and closing motion like that of a hinge door, hence the name hinge. Okay, so like any door that opens and then closes, that's the only type of motion it permits. Okay, in the case of our hinge joints, they permit only flexion and extension, which would be monaxial. Mono or mono, mon means one, so one axis. Okay, and the example of the hinge joints that we have in the body will be your knees and your elbows. Okay, pivot or trochoid joints are where the surface of one bone articulates with the ring formed partly by another, permitting pivotal movement, which is also monaxial. Example would be the radial ulnar joint. That's between the radius and ulna, hence the name. But that's the joint that allows you to supinate and pronate, to move your palms forward or to the posterior facing position. And then the latoaxial joint is between the atlas and the axis. Hopefully everybody remembers the atlas and the axis are the fancy terms for your first 2 cervical vertebrae. C1 is the atlas, C2 is the axis. If you remember back in our axial lecture, the axis has that little projection going up. We call that the DENS or DENS process that fits inside of the atlas, and that's how we form this kind of ring and whatnot, and it pivots. Okay, so that allows you to like shake your head no. Condyloid or ellipsoidal joints are where the convex oval shaped projection of one bone fits in the oval shaped depression of another. They are biaxial, so 2 different axes. Examples would be your true wrist, what we call the radiocarpal, and then the metacarpal phalangeal joints would be where the fingers attach to your hand. So like where you think like where your knuckles are, okay, when you can like do what you can do with your fingers as a result of that connection between your phalanges and your metacarpals, your hand bones. Saddle or sellar joints are where the articular surface of one bone is saddle shaped, the articular surface of the other bone fits into that saddle, permitting side to side and up and down movements, but more freely than condyloid. and that makes them triaxial. Triaxial means that they are going to allow motion in all three axes. And we could also describe them as multiaxial. Those terms kind of get used interchangeably. Okay, but a good example of that would be your thumb, and specifically where the thumb, where your metacarpal of your thumb and your trapezium are, and they allow for you to twiddle your thumbs. And then the most freely movable synovial joints are the ball and socket or spheroid joints, where you've got a ball-like head, like the head of the femur, fitting into a cup-like depression of another bone, in this case, the acetabulum of the hip. Okay, this makes them triaxial. Since they're most freely movable, they permit movement around all three axes in all directions in between. Okay, the shoulders are your truly most freely movable synovial joints. Okay, then your hips are also very freely movable, just not quite as freely movable as your shoulders. Okay. As far as the 6 pictures at the bottom, it's very nice to show those different things, but you don't really need to worry about them. Just make sure you know the information there at the top. Okay. So that's one way to kind of classify the different joints or the different synovial joints. Okay. Table 9.3 on this page, and then table 9.4 on the next page gives you selected joints of, in this case, the axial skeleton. On the next page, the appendicular skeleton, giving a little bit of information about each. We've talked about some of these, like sutures up in your skull, which are synarthrosis, permitting no movement, okay, unless you're talking about in kids, which makes them amphiarthrosis joints. Okay, we just mentioned like the atlantoaxial. Okay, most of the rest of these you probably don't recognize. If I go to the next page, you probably recognize some of these more, and these are the ones that we would typically think of as joints. Okay, we just talked about the sternoclavicular, the acromioclavicular, radial ulnar, wrist radiocarpal. Okay, some of those probably make sense, especially as we move farther down the page. Okay, but as far as the exam goes, I'm not going to worry about knowing these 2 tables. Okay, they were in your textbook. They are great information, but I'm not going to ask you to really recall anything specific from them. So it might be handy, someday if you go on into further schooling. I know most of you guys want to be a nurse, which you don't really need to know joints as much in that profession as you would like if you wanted to be a physical therapist or something like that. So that's kind of why I'm not going to worry about these. But I do want you to know these last few slides where we're going to talk about some of the most important joints of the body and their kind of structural makeups. Starting at the top with our only freely movable joint in the skull, your TMJ, the temporomandibular joint. It's a combined hinge and plane joint formed by the condylar processes of the mandible and the mandibular fossa and articular tubercle of the temporal bone. So it's between the temporal and the mandible. So there's where the temporomandibular joint name comes from. Okay, I usually just call it the TMJ for short. Okay, what we have down here at the bottom are 2 different images, right lateral view. So just looking at the side of the face and side of the head, and this is a medial view. So the head's been cut in half from front to back, and so this will be on the inside of the jaw. Okay, this is a medial view. So this is inside of the mouth here. Okay, and that gives us a view of some of those things. What we cannot see in either picture, and that's okay, but I'm going to mention it anyway, is the articular disc or meniscus. A fibrocartilage disc separates the synovial cavity into superior and inferior components. What we can see in both pictures, actually, and I want you to highlight it in both pictures, is the articular capsule, a thin, fairly loose envelope around the circumference of the joint. Okay. Now, hopefully this is common sense, but in the lateral view, you're going to get a good view of the lateral ligament. Okay, you won't see the lateral ligament here in the medial view. Hopefully that's pretty straightforward as to why. Laterals, because it's on the lateral side. Okay. Lateral ligament, which I want you to highlight, is 2 short bands on the lateral surface of the capsule, extending inferiorly and posteriorly from the zygomatic process to the lateral and posterior aspect of the mandible. Not that I'm going to ask you to know all those details. Okay, I just really mainly am going to want you to identify these things. but the function of that lateral ligament is to strengthen the joint laterally, prevent displacement of the mandible. And the next two ligaments, if you break down those big words, kind of tells you exactly what is being connected. Okay. In the case of the sphenomandibular, it's between the sphenoid bone and the mandible. Okay. And this is what we can see down here in our left medial view very nicely. Here's the sphenoid bone, here's the mandible, and they're connected like so. Make sure you highlight that. We can also see down here at the bottom in this picture, and then back up in our lateral view, what we call the stylomandibular ligament. Okay, it's named the stylomandibular because it's attached to the styloid process of our temporal bone and then down over to the mandible and functions to limit movement of the mandible at the TMJ. Okay, remember that styloid process we talked about, that little hook that comes off of the temporal bone just below your ear hole, which is right here. So there are three things that you need to know in this top image. The three things are already capitalized for you. And then same situation down here at the bottom, there's three things in this medial view that you need to know and they're already capitalized for you. Anything else is not important. All right, let's move on to your next joint, the glenohumeral joint, what we commonly call our shoulder, what we'd really truly call our true shoulder, between the glenoid cavity or fossa of your scapula, which is the depression, little cut that fits the rounded head of the humerus. This is the most freely movable joint in the body. Thinking about what your shoulders can do, it's very significant. We can do just about any and every direction, okay, depending on the condition your shoulder's in, if it's healthy and whatnot. Okay. Now, even though this is a very complicated joint, I've only got one image. It's just a anterior view, so there's going to be some stuff listed above that will not be visible. I'm going to talk about them anyway. So this is just an anterior view. We can see this is the upper half of the humerus, the front side. This would be the front side of the scapula, and we're just focusing in on that connection between the humerus and that scapula, not the connection between the clavicle and the scapula. And a lot of these ligaments up here are more involved with that, so we won't really worry about those. First thing I want to talk about is the articular capsule, a thin loose sac formed by the head of the humerus extending from the glenoid cavity to the anatomical neck of the humerus. Not that you really need to know all that nitty-gritty detail, but I do expect you to be able to identify it. And if I zoom in, you can see where it's pointing right here. Which kind of drives me nuts that they would label it there, because you see all of this white surrounding this like blue bubble. This white material, that's all the articular capsule as well. So they kind of, I don't know why they put the arrow there when it's a lot more visible up here. All right, the next structure we won't be able to see in this image is what we call the glenoid labrum, or some people just call it the labrum. Or shoulder labrum. It's a ring of fibrocartilage surrounding the glenoid cavity and provides a deeper socket. So in order to be able to see it, we'd have to remove the humerus. It's inside of the joint. Okay. So the function of it is just to kind of make a deeper socket for that ball and socket connection. When somebody tears tears like cartilage in their shoulder, more than likely it's a labral tear. I tore my left one when I was in college, and I survived just fine without it. Or not without it, but with a little bit of damage to it. All right, the next structure really is truly not so much a structure associated with the shoulder joint, but it is something that is visible, and I want to talk about it. Okay, what we call the tendon of the biceps brachii muscle is visible. Go ahead and highlight that. Okay, keep in mind, we'll talk more about the biceps in our next unit. It won't be the very next lecture, but the second lecture of the next unit. The word biceps actually translates to mean two heads. Okay, what we see here is one of the two heads to your biceps, what we call the long head, as you can see in parentheses. It runs up and attaches up to the scapula, okay, running through that intertubercular groove, which is the little indentation between the greater and the lesser tubercle. We can see the greater tubercle there. We can't see the lesser tubercle, but it's underneath all that other stuff. Okay. The other tendon, it kind of runs more like this. So it kind of runs a little bit differently, but that's okay. We can't see it, so not a big deal. Now to help keep that tendon of our biceps very firmly against the humerus is a ligament called the transverse humeral ligament, which I want you to highlight. Okay. It just goes from the greater to the lesser tubercle going across, which is why we call it the transverse humeral. It goes across the humerus. Okay. The two ligaments listed above that, I want you to highlight what we call the coracohumeral and the glenohumeral ligaments. Okay. The coracohumeral ligament extends from the coracoid process, hence the name coraco, of the scapula to the greater tubercle of the humerus. Okay. Whereas the glenohumeral ligaments are actually three thickenings of the articular capsule extending from the glenoid cavity to the lesser tubercle and neck of the humerus. Okay. Now, I skipped what we call the rotator cuff, and I'll jump in and talk about that now. I'm sure you've all heard that phrase before. Rotator cuff is a set of four muscles, and there are four tendons that help to stabilize the joint. Okay. Well, the supraspinatus, infraspinatus, and teres minor muscles and their tendons are on the back side. Well, this is an anterior view, so we can't see those three muscles or their tendons. Okay. You just need to know, that they are what make up the rotator cuff, along with the subscapularis. We'll see those in our next unit when we talk about the muscles, where we can actually see the backside of, the scapula and whatnot. What we can see is the tendon of the subscapularis muscle, which I want you to highlight. Okay, but keep in mind the muscle, it looks like that's all it is right here in red. That's not at all the case. In fact, this muscle basically covers the entire front side of the scapula. It sits in that subscapular fossa. And so it's been just cut away right at this point. So we can see some of these more interior structures, like what we call the subscapular bursa, which I want to talk about now. Okay. The subscapular bursa is one of the four bursae associated with the shoulder joint. Okay. We can also see in this anterior view a subacromial bursa. What we cannot see is the subcoracoid, nor can we see the subdeltoid because those are on the back side. Okay. So once again, if you have not highlighted the following, make sure you do. Okay. The subacromial bursa, coracohumeral ligament, glenohumeral ligament, transverse humeral ligaments, tendon of the subscapularis muscle, tendon of the biceps brachii muscle, articular capsule, which, like I said, you might want to relocate the arrow, and then the subscapular bursa. Okay. As I mentioned, a lot of these ligaments up here, like the acromioclavicular, the coracoacromial ligament, those are not associated with the glenohumeral joint. They're more associated with like the AC joint, the acromioclavicular joint. Okay. Now, when people like separate a shoulder, it might not truly be glenohumeral damage, but instead might be like AC joint. So a lot of times these things can be damaged. Okay. But since we're talking just specifically about the shoulder, I'm not going to worry about them. If you do go on to like physical therapy school or something like that, you will probably need to learn those. But for this class, I'm not going to worry about it. Okay, let's move on to the elbow. Which we've got a kind of similar situation to what we just talked about with the shoulder, where you can really be talking about three different things when you describe the elbow. The true elbow joint that we think of as being able to, flex the guns and make a straight arm is the first one. So if it helps you, you might write that down. This is like the true shoulder joint, or excuse me, true elbow joint. It's the connection between the humerus and the ulnar. And it is a hinge joint, so it only allows for flexion and extension. Okay. The humeroradial joint is probably the least important of the three. It is just the connection between the capitulum of the humerus and the head of the radius, just where those two bones meet. Okay, really nothing super important between those two. The radial ulnar, not gradial. The radial ulnar joint is the interaction of the radial head with the radial notch of the ulna, and is not a hinge joint. This is what allows for you to do that supination pronation. Okay, so it allows for that pivotal motion that we talked about. Okay, Now down here at the bottom, we've got a medial view, so looking at the inside of the elbow, and then a lateral view on the outside of the elbow. In both pictures, we get a good view of the articular capsule. So go ahead and highlight that. Okay, I'm not going to read through because it's very significant. Okay, just know that the elbow has a very pronounced articular capsule. Okay, the next two structures I want to talk about are what we call the radiocollateral ligament and the ulnar collateral ligament. Okay, these are on the side of the elbow and help restrict side-to-side motions. Okay, if we think about what we've previously learned, you know, on the exam, if you see either of these pictures, okay, it will tell you if we're looking medially or laterally, so that'll be a helpful guide. But if you can't remember, find the point of the elbow. Okay, that's going to tell you that this is the ulna, because this is the olecranon. That's the point of your elbow. Okay, and you can see the same thing down here. Okay, if it's going from the humerus more down and connecting to the ulna, we call that the ulnar collateral ligament. Okay, if it's going from the humerus more to the radius, right here, we call that the radiocollateral ligament. Okay, if you remember, when you think about what's medial, what's lateral, your radius is lateral. Your pinky side is where your ulna is, and that's medial. Okay, well, it makes sense that the ulnar collateral ligament is visible in the medial view, whereas the radiocollateral ligament is visible on the lateral view. Okay, if any of you guys follow baseball, one of the most common injuries in baseball is a torn UCL, for short, ulnar collateral ligament. Okay, it happens a lot to baseball pitchers. That throwing motion that baseball pitchers are performing, you know, repetitively many times puts a lot of stress on the inside of their elbow. And that used to be a career ender, where, you know, if they tore their ulnar collateral ligament, their, you know, career was over. But now they can perform a procedure. It's called Tommy John surgery, and that's because pitcher named Tommy John was the first one they ever successfully did it on. Okay, so if you've ever heard that phrase before, now you know why. Last structure I want you to highlight, and you can see it in both images, is what we call the annular ligament. I don't care about annular ligament of the radius, just annular ligament is fine. Basically, it circles around the top of the head of the radius and basically just holds it in place. That way, when we do the supination, pronation, the radius doesn't just kind of fly away from the ulna. So it just helps kind of keep it tight up against the ulna. So if you hadn't already kind of picked up on it, it's the three things that are bolded in this top image and the three things that are bolded in the bottom image. Okay, so that's it for the upper body. Moving down to the lower half of our body, we'll start with our hips, or what we call the coxal joints. Another one of those ball and socket joints where the head of the femur sits into the very deep socket of the hip bones, what we call the acetabulum. Okay. First structure I'm going to talk about, not visible in labeled in the images, but it is what we call the articular capsule, very dense and strong capsule extending from the rim of the acetabulum to the neck of the femur. The next structure is another thing that we can't see, like the labrum in our shoulders, that cartilage is on the inside of the socket. We don't have a view here to show the what we call acetabular labrum. This is a horseshoe-shaped ring of fibrocartilage, increasing the depth of the acetabulum. So it works just like the labrum in the shoulders. What we can see in both pictures are the next three things listed there. Okay, we have an anterior view looking at the front of the hip, and then a backside view, posterior view, looking at the back of the hip. And as you can see, all three of those ligaments end with femoral because that's where they attach to the femur. The beginning of the term refers to which segment of the hip that it connects to. Remember, there's three parts to the hip: ilium, ischium, and pubis. Okay, so the iliofemoral attaches the femur to the ilium, or vice versa, whatever you want to say. Okay, it's an anterior ligament, but we can also see it in the posterior view. So you want to highlight it at the top and the bottom. Okay, pubofemoral is strictly visible in the anterior view. It's going to connect the femur over to the pubis. Remember, the pubic part of the hip bone is kind of where the genitalia are, and your genitalia will be kind of just over in this general area over here, so fairly close to where the pubofemoral ligament is. And then on the back side is the only view where you'll see the ischiofemoral, okay, and you'll want to highlight it there. So in both pictures, you just have two things to identify: the two ligaments at the top, pubo and ilio, and then at the bottom, the ilio and the ischio. Keep in mind that these are the absolute strongest ligaments that our body has, and that provides a lot of stability to your hip and keeps your hip from dislocating. Not to say that that's not going to happen. It does happen from time to time, but it is a kind of freak type of accident and a very dangerous one where, you know, they're going to probably put that person in a ambulance and take them directly to the ER to, you know, probably go into surgery. So not a pleasant experience, I would think. Okay, our next joint, I would say, is the most complicated. Our, what we commonly call our knee, goes by anatomically the tibiofemoral joint, and that's because it's between the tibia and the femur, okay? It is primarily a hinge joint where the condyles of the femur and the tibia articulate. Okay. First structure, articular capsule, is not something that you can see in any of the images because it's not a complete independent capsule uniting the bones of the knee. Okay. The ligamentous sheaths surrounding the joint consist mostly of tendons or their expansions. Okay. The image that I'm going to refer to the most, and this is actually the only one that I want you to worry about for the exam, is this anterior deep view. Okay. I've got a superior view that gives you a good view of the menisci. And then I've got a posterior cadaver view where we can see some of those things from behind, okay? Now, in our anterior deep view, we can see the tib and the fib very nicely, okay? What we can see is this is the end of your femur, okay? But you would think, you know, the femur is going up, but this is not a straight leg knee. This is where the knee has been bent. So in other words, the knee's flexed, and so this gives us a view of the bottom of the femur. The rest of the femur is just hidden because it would be behind of it, okay? Now this is a deep view, and that's because we've removed the patella and the patellar tendon or patellar ligament, whatever you want to call it. Commonly, most people will call it the patellar tendon. With a continuation of the common tendon, the quadriceps femoris muscle extends from the patella to the tubular tuberosity. So if the patella and the patellar tendon were here, patella would be covering this space here, and then the patellar tendon would be right here. We wouldn't be able to see any of these internal structures. Okay, so I wanted to mention it, but you can't see it. Okay. So let's talk about some stuff that we can see. The first two structures that we're going to talk about, and I would highlight them, are the two meniscuses, the menisci, what we call the medial and the lateral. Okay, they are going to have a nice C shape. You can see here from above what their shape is like, okay? And they are pads of fiber cartilage that are very important for shock absorption and preventing the femur from rocking side to side on top of the tibia, okay? Now, looking at our anterior deep view, the one you need to know for the exam, kind of tough to tell them apart. I mean, the medial looks smaller, when in actuality it's not, okay? We just can see the lateral a little bit more easily on the left side here. So that's one way. The probably easier and better way, I would say, to tell them apart is to go down here and find the tib and the fib, okay? On the exam, more than likely it won't have tibia and fibula if I put this picture on there labeled, but you can see the big difference between the two. Remember, the tibia is tubby, the fibula is fine, it's skinny, okay? Well, if you remember the fibula, if you add fibula and lateral together, that is where, you know, that's one of the ways I told you to remember it. Fibula is always on the lateral side of your leg, okay? So you know this part of the knee is lateral, so you know this has to be the lateral meniscus, and then this on the opposite side has to be the medial meniscus, okay? That will also help with the two ligaments on the side of the knee, what we call the fibular collateral ligament and the tibial collateral ligament, which is what they are more fancily known as anatomically. Most commonly, though, people call them the lateral collateral ligament and the medial collateral ligament. That's actually how I want you to know them, okay? So in parentheses, or what I would do next to fibular collateral ligament, I would write, you can write the whole thing out, or you can just abbreviate LCL. And then next to tibial collateral ligament, if you want to write medial collateral ligament, or you can just abbreviate MCL. Okay. So the LCL is on the lateral side. It connects the femur to the fibula. Okay. On the medial side, connecting the femur to the tibia is the MCL, or tibial collateral. Okay. So tibial collateral is the MCL, fibular collateral is the LCL. Those are extracapsular. Those prevent the knee from kind of just like buckling in or out. Okay. Whereas the last two ligaments, last two structures I want you to know, also have a similar abbreviation, ACL and PCL, except now notice what the C is abbreviating, whereas before, in the case of the LCL and the MCL, it's collateral. In the case of the ACL and the PCL, it's cruciate. And that's because that term refers to the fact that they crisscross, they form an X in the knee. Okay, these are intracapsular, so they're inside of the joint. Okay, the one we see better here in our anterior view is the anterior cruciate ligament. That's because it's on the front side of the tibia. Okay, it originates on the front side or the anterior side of the tibia, and then it attaches to the posterior side of the femur. Okay, you hear more about people's ACLs. That's one more commonly injured. Okay. An easy way to tear an ACL is to actually hyperextend the knee, because that's what it prevents. If you hyperextend it too much, that'll cause it to tear. So like a lot of times in basketball, if a guy jumps up or girl jumps up and they come down and their leg is straight and it bends backwards, that'll tear it. A lot of rotational type motions will also tear the ACL. Okay. The one in behind it is the PCL, posterior cruciate ligaments. It attaches to the posterior side of the tibia and then into the anterior side of the femur. So it starts back and then comes to the front. Okay, here we can kind of see the two directions that those are going in. Now they've been cut, as you can see, but we get a good, nice view of the PCL here, as well as the ACL and our cadaver knee at the back. But I'm not worried about you knowing that. PCL, actually, I tore that. I get hurt a lot if you haven't picked up on that, but that was all harder to fix. You have to go into the back of the knee, and surgery is not as successful. So I just kind of live with a bum knee on my right side. So
wait, so it's like actually torn?
Mhm.
Oh.
Yeah, I mean, most of the time it doesn't bother me. I mean, like I'm still pretty active and it doesn't bother me. Actually, honestly, one of the worst things to it would be just standing, and another thing would be like kneeling down. I can't kneel and put weight on it, because this is the ligament that prevents the femur from coming like to the front, so sliding off the front of the tibia. Not that that would actually happen, because other structures prevent that, but that's its main job. So I know my limitations, and I can walk just fine. It's been about 15 years or so, so I've been okay with it. Okay, so once again, if you did not highlight the following, these are the things you need to know: the ACL, lateral meniscus, LCL, and then on the medial side here, we have the PCL that you need to highlight, medial meniscus, and then the MCL at the bottom. All those other structures, I'm not worried about you knowing. Now, for whatever reason, the textbook does not include pictures for the ankle. I guess they don't for the wrist either, but that's okay. I do want you to know structurally your ankle joint, what we would anatomically call the talocrural joint, okay, because it's between the talus of the ankle, and then crural, remember, that's the term for the lower leg, and that's because this joint is not just between the talus and the tibia, but it's also the talus and the fibula. Okay, so since the textbook doesn't have pictures, we've got some in the color. Okay, and so I'll switch over to my document camera and do that now. Okay, we've got a posterior view that's just looking at the back of the ankle, a medial view, and then a lateral view at the bottom. Okay, we have the first two ligaments. I'm going to just color those together. What we call the anterior and posterior tibiofibular ligaments. That's the color blue. Kind of doesn't show up very well, but they just kind of help hold the tib and the fib together down there by the ankle. In our posterior view, we can see the posterior one. And then down here in our lateral view, we can see both of the anterior and posterior view, or excuse me, anterior and posterior ligaments. I don't really care about you knowing the difference specifically, although that should be pretty common sense. Just knowing them together is perfectly fine. Okay. Okay, the next ligament I'm going to color, and that's the color green, is the medial / deltoid ligament. Okay, would hope everybody could kind of common sense use their brains to figure out that the medial view is where you're going to find those. They are going to connect the tibia to the bones of the foot, prevent excess eversion. Remember, eversion is where the bottom of your foot tips outward. Okay. If you look back here in our posterior view, we can also see part of them anyway, connecting the tib to the ankle. Okay. On the other side of the ankle are where we can find the lateral ligaments. Okay, and there are two of those, the calcaneofibular and then the talofibular. Okay, here in our posterior view, we can see the calcaneofibular. Here in our lateral view, bottom, where we can see both the calcaneofibular and talofibular. Okay. Those are fairly commonly injured. The other day I mentioned like the inversion ankle sprain is the most common ankle injury. So like when your foot rolls and you put a lot of weight down on that rolled ankle, puts a lot of pressure on these guys. It's fairly common to damage those pretty significantly. So much so that sometimes like breaking your ankle would be better than spraining it because you can really hurt those ligaments. Okay. And then the last structure, I'm going to color it black. It's truly not an ankle joint structure, but it is so tied in with the ankle. And it is a very prominent structure. I'm going to go ahead and highlight it. It's visible in all three images. What we will call the calcaneal tendon, or as most people describe it, the Achilles. This is connected to the calcaneal bone, obviously, it's the name, but it runs up and connects to our big calf muscle known as the gastrocnemius. Okay, and very strong. Unfortunately, it does tear from time to time. When that happens, people describe it as feeling like they got shot in the back of the leg because it hurts so much. So, probably not something anybody would want to experience. Okay, any questions